Thank you. Dear chairs, dear colleagues, dear friends, I am very grateful to be here in front of you today to present the findings of our study involving arrhythmia-induced cardiomyopathy and more specifically tachycardia-induced cardiomyopathy. To illustrate just how tricky it is to diagnose arrhythmia-induced cardiomyopathy, I will start with showing you two patients. The first patient comes to our clinic with a very dilated left ventricle and a very dilated left atria, having atrial fibrillation and a poor left ventricular ejection fraction. We decide to treat the atrial fibrillation using pulmonary vein isolation, and 1 year later we see a dramatic improvement and recovery in the left ventricular ejection fraction, and the mitral regurgitation also improves significantly. So what kind of disease does this patient have? Well, of course, it's the arrhythmia-induced cardiomyopathy, because after treating the atrial fibrillation, the left ventricular function recovered. We have a second patient, comes with a very similar picture, so a very dilated left ventricle, a very dilated left atria in atrial fibrillation. We decide to adopt the same treatment, pulmonary vein isolation, and 1 year later there is absolutely no improvement. Why? Because this patient has idiopathic dilated cardiomyopathy, so we do not know basically which disease caused which disease. Was it the left ventricular dilatation that led to the appearance of the atrial fibrillation, or was it the other way around? Now, what is arrhythmia-induced cardiomyopathy? It's a subtype of acute heart failure that is caused by atrial fibrillation or atrial flutter or sustained tachycardia, in which case it is called tachymyopathy, or it can be induced by right ventricle pacing, and it can also occur in the case of frequent PVCs. Now, regardless of this, there are several questions that remain unanswered, like, is this completely reversible, just like everyone is telling us? How does the left ventricular geometry look like after we treat it? And do these patients have diastolic dysfunction, or do they really recover completely? Does this translate to an improvement of symptoms if we adopt treatment of the arrhythmia? And last but not least, what are the outcomes? Now, these are the questions that we are trying to answer in the AICM registry, which is a retrospective and prospective registry, the largest of its kind in the world. And in the retrospective registry, we have almost 2,000 patients with a suspected arrhythmia-induced cardiomyopathy. And this is the distribution of the arrhythmias in this cohort. Around 80% have atrial fibrillation and 22% have ventricular extrasystoles. And of course, some patients have more than one kind of arrhythmia. And at the same time, we have started the prospective recruitment of patients. At this very point, we have around 400 patients included, but we intend to include around between 1,200 patients to 1,500 patients in the next 5 years at a minimum of 5 centers worldwide. Now, as for the methods of the paper I am trying to show you today, we used some very strict methods of selecting the patients. So the patients had to present with a baseline echocardiographic examination with a very poor ejection fraction and an active arrhythmia, and at the follow-up they had to have a normalization of the left ventricular ejection fraction, or at least 15% improvement in the left ventricular ejection fraction. Then two cardiologists took a look exactly why this happened. Was it the treatment of the arrhythmia that led to this improvement? In this case, the patient had arrhythmia-induced cardiomyopathy. Or was it some other kind of treatment like stenting or like valve replacement therapy? And We included 238 patients, 31% were female, and the median age was around 70 years old. And there was also almost 2 years between the first and the second TTE examination. When completing the gold standard of diagnosis, 127 patients had tachycardia-induced cardiomyopathy, and 111 had other forms of cardiomyopathy, around half of them having ischemic heart disease. So compared to patients with other forms of cardiomyopathy, tachycardiomyopathy patients had a persistent dilatation of the left atria and the left ventricles despite the treatment and the recovery of the systolic function. The fractional shortening improved drastically more than the controls, and almost 60% of the patients had persistent diastolic dysfunction after treating the arrhythmia. These findings were published earlier this year in ESC Heart Failure, but there are several questions remaining unanswered, like, is arrhythmia-induced cardiomyopathy truly a new cardiomyopathy? For this, of course, we need outcome data, and there is truly no data currently published, and we are actively working on it. And I would like to show you some of the preliminary results. So regarding the rates of heart failure decompensation and cardiovascular hospitalization, we see that tachycardiomyopathy and other forms of cardiomyopathy look basically the same. So the rates are comparable, with the mention that in case of isolated tachycardiomyopathy, the rates are a little lower because most of the patients can also be treated ambulantly. Now, the most important probably is the rate of death and life-threatening arrhythmias. And here we see basically the first problem. Patients having tachycardiomyopathy, isolated, but also overlapping on some other form of cardiomyopathy, so impure tachycardiomyopathy, have worse outcomes. Of course, the numbers are very small, and there is a low number of outcomes, so this can also be just a matter of randomness. But this raises an alarm signal that we may have missed this kind of arrhythmia for quite some years. To draw a conclusion is way too early, I think. But what I can already say is that arrhythmia-induced cardiomyopathy has been missed for years, that each arrhythmia-induced cardiomyopathy episode leads to a further remodeling of the left atria and the left ventricles, and that despite the recovery in the left ventricular ejection fraction, persistent diastolic dysfunction is very common. The first look at the outcome data provide a worrisome perspective from my point of view, and for this reason, early discovery and treatment of this kind of acute heart failure is warranted, but at this moment is very hard to do. Thank you for your time.
Yeah, thank you very much for this elegant presentation. So please.
Thank you for the presentation. Which is the cutoff for considering tachycardiomyopathy? If it is 100, or what do you consider this is tachycardiomyopathy? It is related to the heart rate.
For the purpose of our paper, we use the heart rate of 100 beats per minute to name it tachycardiomyopathy. But of course, in case of atrial fibrillation, we know that the frequency varies a lot.
I have also a comment. From a clinical point of view, there is also a clinical dilemma in emergency department. If there is pre-existing dilated cardiomyopathy, a non-dilated cardiomyopathy with new onset atrial fibrillation versus tachycardia-induced cardiomyopathy, which is the factors that will recognize its condition in this setting? The dimensions, the reversibility after restoration?
So in case, I can only speak about the atrial fibrillation because there has lately been published a score to predict patients that will recover the ejection fraction after treatment of the atrial fibrillation with pulmonary vein isolation. This was the Antwerp study and was published some days ago. And they found that in left atrial dilatation, patients with paroxysmal atrial fibrillation and patients having no known etiology of heart disease are likely to recover, so that are likely to have arrhythmia-induced cardiomyopathy. And this was validated in our hospital as well.
Okay, one final question in the back.
Hi, thanks a lot for the talk. I'm just interested that the patients who go back into sort of sinus rhythm, you say the diastolic filling pressures are still high and that doesn't resolve. And I just wonder if you thought about these patients are actually on the spectrum of the heart failure preserved ejection fraction, and actually their risk of arrhythmia is just higher, and whether or not the baseline demographics are different from heart failure reduced ejection fraction, if you know what I mean, in terms of their weight, prevalence of comorbidity like hypertension and diabetes, etc.
So from our data, there does not seem to be any baseline differences regarding patients with preserved ejection fraction and reduced ejection fraction. They are, from our point of view, they are comparable, and there seem to be some completely unknown factors that are leading to a worse decrease in the systolic function in these patients. But at this very moment, we are unable to tell you, I'm unable to tell you exactly what are these factors, and we are giving our best to research it in some further studies.
Okay, thank you.
Thank you.
Let's move to the next speaker.